ODR surgeon, and the diabetic surgery and the retinopathy of prematurity are probably the ones which take a longer time to go on. The indications for vitrectomy are basically non-clearing vitreous hemorrhages, TRDs or combined RDs, one-eyed patients with macular hemorrhages, macular distortion, macular edema with vitromacular traction, or anterior hyaloid proliferations. So the goal in PDR surgery is basically first to clear the media opacity, important in patients where we get recurrent vitreous hemorrhage, and gives us an idea about the sclerotomy sites, whether there is a fibrovascular proliferation or an anterior hyaloid fibrovascular proliferation. It's important to know the pathoanatomy, where there is a point attachment of posterior hyaloid, a dense attachment which is broad attachment, or there are multiple focal attachments of the hyaloid causing the traction. Here we don't use suction to induce PVT, and we have to do a complete 360-degree truncation of the bone. That is, make a nick in the posterior hyaloid and then continue 360 degrees so that we don't cause any traction, anteroposterior traction on the fibrovascular proliferation. It's again important first to clear your sclerotomy sites well so that you can further do dissection. It's important again to recognize vitreous chiasis and second membranes. These are shiny taut membrane much beyond the fibrovascular proliferation, which have to be visualized, and then only we get the plane of the dissection. Some important tips could be when we are trying to suck the blood through the fluid needle, it's not getting sucked because there is a membrane. It's difficult to visualize the peripheral limit of the second membrane. Sometimes a spatula or a nanoscraper may be useful. Patients where there is no posterior vitreous detachment and there is a taut posterior hyaloid, again, instead of using suction, it's better to give a nick with the MVR blade in the posterior hyaloid and then continue the dissection with the scissors and the cutter. Coming to the membrane dissection, we can use segmentation, that is, dissection of the fibrovascular proliferation into small pieces and then cutting it with the vitreous cutter. Here you can see a scissor segmentation where the vertical scissors are used. We have to insert the scissors in between the nail attachments of the fibrovascular proliferation so that we are not making any retinal breaks. And then divide it into smaller pieces which can be easily cut through the cutter. The dissection can be from the periphery to anterior or from center to the periphery. Another modality is delamination, where we go underneath the fibrovascular proliferation, identify each epicenter, cut it with the scissors, and remove the membrane in toto. Here you can see there is a combined retinal detachment. Using curved scissors, we're going under the proliferation, trying to identify the epicenters and making bold cuts, so as the whole proliferation can be removed and later cut by the cutter. Another technique could be bimanual dissection, where we fit a chandelier and then holding the edge of the vitreous, we can use both the hand and use the forceps for the dissection. These are mostly patients, young patients, where we have taut posterior hyaloid as well as taut attachments of the vitreous. Later FG and laser can be done. Patients where there is attached retina and the fibrovascular polyp is more fibrous, we can even use the forceps or the scissor to pick it up and peel the membrane. But it's not advisable for patients where there is more vascularity and ischemic retina, or where there is a combined detachment. Some patients, the adhesions are very taut, and after we have dissected the proliferation, it's still very difficult to detach this hard fibrovascular proliferation from the retina, and we have to do localized retinotomy to relieve the traction and to settle the retina. Like you can see here, we are using scissors. To relieve this traction, there is a retinotomy, and after that, fluid gas exchange and laser is done. Laser is another difficult problem because of chronic tractional detachment. It's difficult to get the laser marks. It's difficult to even do a complete fluid gas exchange. Here we can use selected cases endo-cryo to the edge of the braid. It's important that we do good debulking of the vitreous before we proceed to the membrane surgery. The movement should be more controlled. The magnification should be higher when we are dealing with these membranes, and we should be defining epicenters before using the scissors. With the advanced techniques, with the new cutters coming, it's very easy now to go near the retina and do a carpet rolling of the fibrovascular proliferation. This patient is following bevacizumab. So you can see the ease of the dissection. The cutter is used for segmentation as well as now we are cauterizing the small oozes. After segmenting, the cutter is used to remove all the proliferation, and this is after fluid gas exchange. You can see the florid vascularity, and here we can use the bevacizumab, but you can see post-op following bevacizumab, still the large vessels persist. It's only the smaller vessels which get affected. This is a surgery following intravitreal bevacizumab. You can see the proliferation has become so fibrous and it's easily coming in the cutter. This is a carpet rolling technique where we are using the cutter to roll the polyp, and the polyp is on its own coming to the cutter. Bleeding is quite less in these patients. And laser can be done. So the most commonly complication what we follow is the bleeding. And intraoperatively, some small bleeders may spontaneously cease. We may increase the intraocular pressure. We may use FGE. We may even use viscoelastics to, reduce this bleeding. Sometimes diathermy or endolaser can be used. People have also described the infusion of thrombin, aminocaploic acid. And anyways, the pre-op anti-VEGF is again a very good tool in our hand. Another indication of vitrectomy in diabetes is the diabetic macular edema, which will not respond to intravitreal injections, and there is a taut posterior hyaloid either causing traction. So the role is basically to relieve the macular traction, to resolve the macular detachment, and basically to remove the toxic substances from the preretinal space. It allows increased oxygenation. Here there is a video where you can see spatula is used to remove the epiretinal membrane. Triamcinolone is injected to stain the ILM, and here ILM is being peeled in a diabetic patient. Be cautious in removing this ILM as it may deroot sometimes the cyst. So use minimal force and don't try to peel through the macula. This is another patient where there is a diabetic macular edema with vitreoretinal adhesions and tractions, where there is a plaque of exudates at the macula. After making a retinotomy, these plaques are removed. And retina is attached. So we can do a sharp dissection even with a nice spatula which is available, and we can dissect the proliferation. Sometimes viscoelastics may help to dissect these proliferations and to identify these epicenters. Scissors delamination, it is definitely required for firm attachment. We may not be pulling the proliferation all the time. It's better we don't allow large clots to form, because that is the time when we finally find to have iatrogenic breaks. These blood clots, they tend to follow the same structural adhesions like the membranes, the same epicenters, and it's better to start from the attached retina and then come to the detached retina by peeling. Thank you so much for the attention.
Rishi for inviting me to be part of this instruction course. And we're basically talking about trauma and a case-based approach where we approach different trauma cases, posterior segment trauma mainly in different ways. In trauma, the rule that we all know is predictably it is unpredictable, and we really expect the unexpected all the time. So I'll be presenting an assortment of cases which will highlight the various challenges and surprises that we face in managing trauma. So it's a 50-year-old male who presented cerebral trauma with a metallic object, and we were suspecting intraocular foreign body along the cords. Right. So the first lesson that we learn in trauma management is proper exploration of the wound. And sometimes when you properly explore the wounds, here in the case, after only the 360-degree exposure, we could find a large iron foreign body just at the fornix. So proper exploration of the wound where you're not able to localize the wound gives a good result sometimes. These are pleasant surprises that we always don't have. Another case of an elderly gentleman who presented with us trauma, and we have this cystic lesion just sitting above the superior limbus. In rare cases that we see, so again, any posterior segment trauma, you first localize, open the conjunctiva nicely, dissect the tenons, look for the structure, what is that, and look for also associated injuries like scleral tear. So here basically it's a dislocated crystalline lens that we see here, and the rest of the surgery was really easy, just taking out the practice. So the big question when you present with a severe posterior segment trauma is whether you go ahead with a primary surgery or a stage surgery, that is you repair the corneal tear, the scleral tear, and go for the subsequent management later on. So there are multiple considerations that go behind it, like whether there are any serious non-ocular injuries that are very common in road traffic accidents where you might not get the window opportunity to treat the eye. First you have to save the patient. Corneal clarity is a big determinant of whether to go inside and operate. Presence of infection, intraocular foreign bodies are the conditions which really put us in a fix, and we have to go early in these cases. Obviously, sedation of retina and the choroid, like suprachoroidal hemorrhages, it's very common to have huge kissing suprachoroidals after large scleral tears. When you give them a course of oral steroids, wait for 2 weeks, and the choroidal resolves, you can go ahead for surgery. So the principles of So this is a patient who presented with a scleral tear, and so the principles of trauma repair are basically well known. You first attempt for integrity of the globe. Watertight suturing is important. Same patient, you see there is severe hypotony. You can see the cornea is almost going inside. So in these cases, if you want to plan surgery, the first step you need to do is you have to form the globe. Because unless you form the globe, if you want to go inside that globe, put in a cannula, you're going to damage either the lens. Most of the trauma cases, the retina is incarcerated anteriorly. So most of the times, if you want to go for a primary surgery in a hypotony eye, you can go in a 30 gauge cannula and form the AC very nicely. So when the AC is formed very nicely, as you can see here, we can go at subsequent surgeries. Lens management, as Dr. Pukhraj has shown us few of the cases, there are multiple ways you can tackle a lens. You can do a lensectomy. You can do a lensectomy with preserving the anterior capsule. And if you have a small intraocular foreign body, you might do a phacoemulsification. The principles of vitrectomy in trauma are essentially same. You go for complete vitrectomy, base excision. The most important part is proper PVD induction is very important. In some for trauma cases, we do have a pre-existing PVD, but still in some cases there is no PVD at all in spite of trauma. So their IVD assisted PVD induction is really helpful. This case basically shows put IVD and the 20 gauge cutter, you can just peel off the posterior highlight above the mobile retina. You have to be careful because in these cases sometimes the retina can come into a cutter port and create highlight and breaks. So PVD induction is a very important stage in any case of trauma. Another very important consideration when you operate cases of trauma is the amount of subretinal blood that we have. You have to remember that it is imperative to clear all the subretinal blood because subretinal blood is a leaders for the PVR, can cause retinopathy and cause a lot of inflammation. And apart from the fact there is just a lot of scarring. So in this case, as you can see, there are large pre-existing breaks, so it makes our job easy. We can go with the soft tip fluid and go right beneath the macula and clear the subretinal blood. Other option is PFCL assisted drainage of the subretinal blood. You can see a lot of blood there. This video is not clear. You can put a bubble of PFCL and drain through peripheral retinal breaks. Another very common situation in posterior segment trauma is retinal incarceration. There are various managements that you can do for retinal incarceration. So this is a case of, again, a large intraocular foreign body. You can see the foreign body is here. It is being taken out as per the sclerotomy. You can see there is a fold of retina going here. There is a dry fold of retina. The retina is not incarcerated here. But there is a retinal incarceration here. So this kind of retinal incarceration will not settle if you don't do a retinotomy here. So relaxing retinotomy is a very important step in relaxing this retinas. So after you relax the retina, you go ahead inside the subretinal space, clear blood, and then you can put LPFC and the rest of the surgery is routine. Sometimes peripheral incarceration, you can plan to put a scleral buckle also, though over a period of time we have really shifted away from putting scleral buckles, we are going more for vitrectomy. Sometimes you really have to think out of the box. So this is a very young gentleman with a very clear phakic lens, 25-year-old, who had a large copper-ware foreign body inside. You can see, I don't know whether you're able to see or not. There is a copper-ware foreign body. It's a bow-shaped foreign body. So we first dislodged it from the retinal side gently with a cutter, but it was very difficult to bring it out through the sclerotomy. It will not come out through the sclerotomy. Because the moment you try to bring it out, it will either touch the lens and you have to sacrifice the lens. So what you do is, you go with the chandelier light, go through instruments and straighten the foreign body inside the eye and bring it out through the sclerotomy intact, not damaging the lens. We had one very unusual case, a 20-hour-old baby actually. The baby came right out of the NICU into our hospital with a forceps trauma. And on presentation, you can see there is severe corneal edema, there is blood in the AC. Yeah, and primary surgery was resuturing, there was air bubble in the AC, and after the primary repair we found there was a retinal detachment inside. Looking at the amblyogenic age, large retinal detachment, we decided to go at the combined surgery. These are the cases which needs a combined procedure, a PK and a vitreoretinal surgery. So first we put a temporary keratoprosthesis. In such small child, it's very difficult. Even the smallest size of keratoprosthesis is feeling almost full of the glow. So it is quite difficult to handle such difficult small child. So as you can see, there is a lot of vitreous hemorrhage inside. So first step, obviously, the principle is creating completely clearing of the vitreous. So what we see inside is there is a lot of hemorrhages over the retina, and there is a giant retinal tear that is in the temple. I don't know whether it's visible or not, but you can see there are multiple. This is a giant retinal tear that you can see. So, and there are multiple blotchy hemorrhages in the retina. So then the rest of the surgery was actually easy. You put LPFC, flatten the retina. The important lesson here is in cases of severe trauma in children or where there is extensive corneal edema, you might have to plan a combined surgery. Suppose we get the patient is doing well. So thank you very much for your time.
And we will be talking about vitrectomy in giant retinal tear.
Thank Dr. Ikhtarishi for giving me the opportunity to present in this IC. So I'll be talking on GRT. I don't have any financial interest. Now, this is the photograph of the surgery to have a retinal attachment with GRT like this and to have a conversion to have attached retina post-operative period. So if we just go through the few initial information, it's a retinal break that extends more than actually with posterior vitreous detachment, and it's a cause of retinal detachment in 0.5 to 8.3% of cases. There are reports of its annual incidence of GRT. There is a male preponderance, right eye is commonly affected, and we all know about the landmark study by Dr. Freeman, reported 12.8% of bilateral GRT at a 16 years follow-up. There are a few challenges which we'll describe along with the videos. It's most commonly seen posterior to ora in around 82% of cases, followed by equator and posterior to equator. It's most commonly idiopathic, it around 55 to 60% of cases. It's traumatic, followed by traumatic hereditary retinopathies, myopia. There are a lot of iatrogenic complications, especially in cataract surgery, while to recover the lens, drop nucleus, intraocular foreign body retinopathy, LASIK, and few other conditions in NADL, glaucoma, retinitis pigmentosa. So the pathogenesis in GRT, we usually have a really abnormal retina and vitreous liquefaction, and it starts with circumferential vitreous traction causing anterior taut membrane, which actually makes retinal ridge adjacent to the area of fibrillary pressure. The straight retina ribs and forms GRT at the base of the pupil. It extends very fast, and that's more important in case of GRT to reach when 360 degree within weeks. I'll just go shortly through clinical features. Mostly the patients present with immunosuppression within 10 days, and this is more important. More than 50% of patients with GRT present with PVR grade B during presentation. Now, if you're not able to visualize the fundus, you can do ultrasound, and the characteristic double linear cosine can be seen here. So there's absence of retinal echo in at least one quadrant corresponding to the GRT, and you can view the anterior flap. You can figure rotating the transducer. So preoperative evaluation, apart from extension of the retinal tear detachment, assessing choroidal detachment if any, and extension and severity of the PVR, we need to see whether there is vitreous attachment and mobility of the posterior flap and clarity of the media. Examination of the fovea is very important, and along with the patient selection and counseling. So macular detachment, aphakia, hypotony, poor preoperative visual acuity, advanced PVR, and more than 180 degrees are usually associated with poor visual outcome post-operatively, and definitely the extensive dissection during surgery, relaxing retinotomy. So we come with a decision about doing buccal or vitrectomy, vitrectomy with or without encirclage, lens sparing or lensectomy type of component. So we'll just discuss along with the steps. So buckling, it's definitely advantageous. We having one quadrant of GRT with no PVR. Adequate treatment of the flaps and lateral horns can be done with cryo. Mild grade of PVR with star pose in one quadrant can be managed, and we need to have a low broad buckle and support the star pose, because there are always disadvantages of buckling. To have fish mounting, to have retinal slippage, distortion of the globe intraoperatively, retinal folds, and recurrence. So vitrectomy is mostly indicated. Mostly surgeons are managing with vitrectomy, the GRT. And it's indicated in severe PVR, in GRT more than 180 degree, and trauma, immense dislocation, intraocular front body, and vitreous hemorrhage. This patient actually was having a large tear more than 270 degrees attached to the middle part of it as like a stop, and so there is no other option of doing anything other than vitrectomy. So encircling band usually preferred if we're not doing a fixed RF. So it's preferably in phakic eyes in cases of advanced anterior PVR to support edges of break, but and inferior breaks also. But the complications and the disadvantages are same as putting buckle. Lensectomy IOL removal is indicated if you're having anterior PVR, cataract changes, peripheral PCO falsification, lens or IOL dislocation or subluxation, and trauma. So the parts of doing vitrectomy, you have to do a thorough vitrectomy with maximum removal of the base. Doing vitrectomy with removal of the anterior vitreous, and we go to the lateral horns. You can see the fold here. You can see the fold here, and we are replacing the lateral horns and the inferior horns, and we're doing a saving on base excision in the tensional part as well as in the part of the attached retina. So complete vitrectomy at horns of GRT and edges of tear. So this was actually operated bimanually to have a better view of the video, and sometimes you can do cryo also at the edge if you are having very anterior GRT where you need to localize the flap. Difficulties that in case of GRT management, sometimes we get a few vitreous fibrils attached to the posterior retina despite a PVD, and sometimes removing that one or trying to remove that one sometimes we can have very high mobile retina and can have atrophic breaks. So this patient, there are a few vitreous fibrils in posterior flap. You can see very high mobile retina and great atrophic break here. Managing the PVR in case we match your preretinal membranes, we can stain with IVT and spatula and forceps, we can remove the membranes, but difficulty identifying the membranes always leads to incomplete removal. Mature or subretinal membranes can have bimanual dissection, but iatrogenic break residual fraction, large relaxing epinotomies are having their own disadvantages. You can have choroidal injury also during if you are trying to remove subretinal membranes. There is risk managing PVL, but this patient was vitrectomized elsewhere for endophthalmitis, presented with presumably mobile retina with almost 270 degree of diametral tear. So there are a few subretinal membranes here, which you can need to assess initially that to remove the subretinal membranes. And once you feel that it will be okay, you can try to have some amount of posterior pole PFCL and see whether the retina is flattening. But this amount of folds, these folds will be able to recognize once you put PFCL. Try to flatten your spatula, it's not going. So again, you have to reduce the amount of PFCL, go subretinal space, and remove the membranes at whatever extent possible. Then again, you put PFCL. So using PFCL, see, injection should be very slow, should be over the desk. Rapid injection usually leads to a lot of bubbles, subretinal bubbles. Cannula tip should be always inside the bubble. Infusion, you can put semi-off, and you can see the color of the disc changing during putting PFCL. So the CLA pulsation monitoring is very important if you're putting PFCL, and should be always slow. You can tilt the globe towards the end of GRT to flatten it with the PFCL, and you should avoid hypotony because the possibility of folds, possibility of subretinal migration of PFCL is more if you're having hypotony, and PFCL should be always above the level of the tear. But sometimes we get a lot of patients where there's a possibility that during PFCL you can have a iatrogenic macular rotation. So flap of the retina, attached retina, can be kept till the end before we cut it. Managing the anterior and posterior flaps will go according to the videos. This patient was having that first video. At the equator, so you can see two bands. These are the anterior flaps, which are removing along with the vitreous. So anterior flaps has to be excised as much as possible. And if it's phakic, it's okay. If it's phakic, then definitely with depression, you have to remove as much as anterior flap, redundant flaps. Posterior flap in the same patient, you can see a lot of curling and rolling of the lateral edges. So under PFCL, you can try to gently stroke with the spatula. You can try to flatten it. You can put a little more amount of PFCL, and subsequently you can try to flatten the retina by gently unrolling with the tears. But compared to this patient, this young patient was having reasonably okay with no PVR changes. So once you have done good vitrectomy, putting a PFCL, you can flatten the posterior flap nicely. Do extends more to the anterior part. There's another one patient, the same patient where we have put more PFCL, and then we are planning to do the relaxing epinotomy. So be very careful with your cutter because you can have iatrogenic choroidal bleeding, such as this one. But in this patient, very young patient having a large posterior tear, subretinal heme, IDT was used to induce PVD, and then it was lasered under HG. The PFCL is not required in this posterior large tear. Now, retinopexy, 360-degree laser shows an anatomical reattachment rate of around 90% in several studies, and we prefer to do 3-4 rows of staggered pattern of extension laser and extension to the horns, supplemental barrage if we get a persistent SRF in patients. But in phakic eye, anterior treatment can be done even with indirect ophthalmoscopy, laser indirect ophthalmoscopy, because with TSC, most of PVR rate is more if the GRT is more than 180 degrees. So this was the patient having laser after we have flattened on the PFC, the peripheral edge of the posterior horn. recurrent RD in eyes with silicone oil tamponade was less than gas, 12.5% was 31.1%. Post-op complications are comparable in studies. Risk of anisometropic amblyopia in children with silicone oil injection is to be kept in mind. There was no difference in outcomes between the two groups, which was done in the Lipschen study, Lipschen and gas, in terms of retinal detachment rates, 38% Lipschen versus 49.4% overall. So once we start the PFCL silicone oil exchange, we have to start with, after removing the anterior fluid, once we start putting the oil, then remove the fluid between the oil and the PFCL meniscus, I will show you in the next video. And keep the tip in anterior PFCL meniscus, PFCL removal in anterior to posterior direction, and fluid tip of GRTH to flatten and dry the anterior retina. So this is the meniscus, it's not visible properly. This is the meniscus of PFCL and during exchange. We're just removing the fluid first. And then you be in the center of the PFCL with the fluid, be over the disc, so avoid inadvertent trauma to the retina. And you can remove the whole PFC over the disc.
So can you try to conclude fast? We're running short of time.
So anatomical primary retinal detachments are between 77 to 94% with partial atherectomy alone, and between 68 to 96% with combined with buccal. And functionally, BCD improved to, in 50% of patients in most studies and deteriorated at least 40% of cases when compared with the presenting vision. It was in British giant epidemiological study, it was 42% of patients that had BCD of more than 20/40. Out of these complications, in case repair, tear extension, rotation of flap, this was a patient we had a choroidal hemorrhage, and this patient had a recalcitrant retinal fold even after surgery. Post-operatively, we can have redetachment with BVA, inferior BVA, and we have had barrage this patient. Cataract, increased IOP, hypotonic, and sometimes subretinal PFC, which can be very dangerous. So, fellow eye, I just conclude that there is still no evidence to support or refute the use of 360 prophylactic treatment in fellow eyes of with GRT. In only Stickler syndrome, we have a prophylactic laser which may be helpful. And still there is no consensus on the need of prophylaxis and where to treat. There is an advances. I think after that, most of us are trying 23 and 25 gauge treatment. Adjuvants in managing PBS, steroid, anti-metabolism, or reducing newer antigens, TGF, beta, ETGF. Thanks a lot. Thanks for the question.
Thank you, Dr. Suresh. Just one question.
23 gauge, because visual listening is quite comfortably done in 23 gauge, but initially used to do 20 gauge can be definitely done with
In post-operative period, how you will like to manage that?
Depends upon the size of the PFC bubble. If we see it's significantly less, then probably we'll need to monitor every weekly to see the chances of whether there is an inflammation, whether there is any increased eye pressure. And if the patient is okay and retina is attached, there is no inflammation, IOP is okay, reasonably small PFC level, we can safely wait. And we can plan for some early SOR if retina is attached. But if it's significantly big, then definitely we have to plan resurgery and remove it. Otherwise, we having a risk of inflammation as well as IOP.
Thank you so much. Just few questions to the panelists. I'll begin with Dr. Chetan Rao. Again,
I would still prefer the smaller gauge detectives, because even though it takes time, but they do their job pretty well. We are going away from 20 gauge for most cases now. So 25 gauge, even if 27 gauge is available, I think we can do the surgery quite well. And the machines are pretty good. The vacuums are very good. We don't get the retinal incarcerations or retinal. We don't inadvertently. Much safer. And in fact, with the smaller gauge, you probably have smaller breaks, hydrogen breaks, rather than if you do with the 20 gauge.
regarding recurrences of inflammation underlying, how you would like to manage?
Well, if it is a continuation, it's an extension of the ARN, then we probably have to go with a long-term antiviral therapy. Because usually we do a surgery when we're safely, we're quite sure that the inflammation has died down, But despite that, if you have recurrence inflammation, then you have to keep them on long-term antiviral therapy along with low-dose steroids.
Thank you so much. Now, two quick rapid-fire questions for Dr. Pukhraj. Just want to know how you would like to manage no PLIs who have metallic intraocular foreign body. And the second question is how you would like to manage eyes which have long-standing intraocular foreign body with extinguished ERG.
So, no PL is not a contraindication in the setting of acute trauma to intervene. As a principle, we try to get the eye rid of the foreign body, because the foreign body tends to increase many folds the chance of endophthalmitis and very bad prognosis. So the second question is about that is not a contraindication for removing the foreign body if it's reactive, it's causing inflammation, and if it's the risk-benefit ratio favors its removal.
Yeah, I do agree. We do have patients with chronic intraocular foreign body where there was extinguished ERG and patients have been maintaining 6/6 and 6 vision for almost 10 years. So it's always advisable to go ahead and remove these intraocular foreign bodies. Thank you, Dr. Pukhraj. My next questions would be for Dr. Parveen. How will you decide patients with ROP, where you would like to go with encirclage and where you would like to go for a lens-sparing vitrectomy?
It's primarily a peripheral disease that we are looking at, and maybe we can get away with an encirclage. But if it's a progressive disease where the macula is involved, then definitely lens-sparing vitrectomy has to be done. But there are no fixed dogmas, because there have been cases in ROP as well where I have combined the LSV with belt buckle. Sometimes some cases come to us, for example, this particular case that it reminds me of. The baby had laser elsewhere, but the laser was probably not very adequately done, as a result of which the anterior area, which was not lasered, continued to progress, and there was development of fibrosis in that area, which extended from that anterior area onto the disc. So, without sacrificing the lens, it was impossible to combat the fibrosis which was there in the periphery. So I chose to use a belt buckle to reduce the traction in that area. And all the vitreous cases and the membranes which extended from the peripheral area onto the disc, I went in and cut with the LSV. The patient is doing quite well. So sometimes you really have to mix and match.
These babies where you put encirclage and then remove at 1 year of age, as you said, what is the follow-up myopia in these patients? Is it something different from lens-sparing vitrectomy patients?
Follow-up myopia, definitely with the band in situ, is going to definitely affect the development of the eye, because the eye cannot now increase in the diameter, so it increases in the axial length, so it can deform the shape of the eye. But once you have removed it, then the eye is free to grow as any other normal eye would. But induction of myopia in ROP is quite controversial. We really do not know what factors cause it really, because sometimes he has had studies which say that LSV is actually protective, because the laser causes stretching of the thinning of the retina and induces more myopia. But others have said that if you the laser has no bearing on the development of myopia. So we really would need large-scale studies with removing a lot of confounding factors to really know what is causing the myopia. But yes, with the belt buckle in situ, I definitely believe that the growth of the eye will be in a different shape, which could perhaps affect the refractive error.
My next question will be for Dr. Rupak, who has spoken about the trauma. I just want to know.
Traumatic cataract, when the retina is attached, whether to put lens in the primary setting or in the secondary setting is the question. So there are a number of factors that we need to assess before we do that. Remember that in case in amblyogenic ages where the patient is supposed to go into amblyopia very fast, we can consider putting in lenses very fast. But there are certain issues in putting IOLs, like calculation of IOL power, because the corneal surface is not regular and the DBR calculation becomes very difficult. So in those situations, we might consider putting the suture, wait for 3 months, remove the suture, let the astigmatism stabilize, do a SIM-K value, and then go for the secondary IOL implantation. That should be if there is no hurry. In case of very young child, like 4 years, 5 years, that times we might consider putting it early.
I'd probably like to add another thing to it, that if you are able to 4 and 5, yeah, there is a risk of amblyopia, but then the patient does have 4-5 years to recover from that amblyopia also, but he doesn't have that much of time to recover from trauma. So they can recover from trauma and then early visual rehabilitation, and the secondary IOL is probably the best thing to do. Otherwise, so much of inflammation, intraocular lens, intraocular foreign body, retinal detachment all put together, sometimes you may skew your aim altogether.
Great. Again, it's very difficult doing DBR for these eyes. So probably small corneal tears which are in the periphery where you're able to obtain good keratometry probably may have the good cases probably where you can think of primary intraocular lens implantation. But you may get IOL surprises later on and maybe more inflammation. Another question I wanted from Dr. Rupak was, if there is a vitreous hemorrhage and after trauma, the retina is again attached on ultrasound, you will like to wait and watch, or you will like to go in for a surgery?
You are probably in case of maybe diabetes or there is occlusion related vitreous hemorrhage, but again we have to assess certain factors like whether there is an inflammation in the eye, corneal clarity, and an ultrasound. We should also look into status of posterior vitreous detachment. That is also very important prognostic factor, and the surgical success depends on these facilities. So if you find a good PVD, you might go in early within 1 week, but we should not wait more than 2 weeks post-trauma cases. We should operate early in post-trauma vitreous hemorrhage cases.
You don't know the cause of vitreous hemorrhage, from where the vitreous hemorrhage has come, and yes, you may like to intervene.
Do you really find a need for endocrine proof, like just for to complete the talk we have this endocrine proof?
We do tend to use endocrino so many times when there is chronic tractional retinal detachments. These patients have a skytic retina, and you tend to do actually the posterior edge still may be having some fluid and skytic change. Candidate where we can consider doing endocrino to the posterior edge.
Scenario with Ozurdex, after how many injections of anti-VEGF would you like to do vitrectomy and vitrectomy vis-a-vis Ozurdex?
Very good question. Any intervention if they are not finding any vitromacular traction. But looking at our cases where there is a financial constraint, if there is no posterior vitreous detachment, patient has already undergone injections for anti-VEGF or steroids, still not responsive. Yes, that is the choice where we have significant macular edema because we don't want more cystic changes to set in. We are not finding a response, that's the only way where we want to consider. Yes, please call.
I wanted to ask you 3 questions. Number 1, how many days pre-operative would you prefer to give bevacizumab for a diabetic vitrectomy where you are in
retina is attached or there is already tractional detachment, one thing. There is a separate, I usually see juvenile diabetics, they usually will not do that well very early, to wait more than a week because traction definitely sets in.
Second question was about if there is a fibrous proliferation on the disc, what do you prefer to peel it or do you prefer to just truncate it?
This fibrovascular proliferation is associated with peripapillary traction. Whether you have relieved, then you can very well trim it and leave it. But if still there is a traction, you have to dissect it out.
Exudates.
These are the exudates.
Yeah.
It's still a controversial thing which is not something which is published in the literature. These are some things which we have seen in our practice, but still these are such chronic retinal detachment patients and that they don't improve that well in their visual function even after this. But yes, there is...
I would know what the role of anti-VEGF is given at the end of the vitrectomy in cases of severe...
if you're talking about rebleeds, right?
Yeah.
Yeah, you're worried about rebleeds, but I don't feel so we have any role in giving an anti-laser, and whenever these bleeds occur, they tend to clear off very fast later on.
Probably I would only think of one scenario where we have given an anti-VEGF at the end of surgery, and that is probably in ROP. what happens is, as I showed in a few slides also, there's a lot of bleeding, and these clots you cannot really remove because you may have breaks while you at the end of surgery in the eye, which is documented in literature also that people have done it. Not for any other reason, but want of, at least you don't have to repeat a general anesthesia to give it later on. Because in the baby, you may have to bring the baby again for a checkup. So here, in few cases, few scenarios, people have left or closed the eye with a intravitreal anti-VEGF.
Another indication probably where I like to give anti-VEGF following the surgery would be a breakthrough bleed after PCP. Where immediate.
Like to give anti-VEGF.
Most of our cases we prefer not to give anti-VEGF and florid neovascularization where it's coming into the vitreous, and these are not very mature vessels as I showed you. The mature vessels which are already present may not respond to anti-VEGF. These are only those capillary-like thin vessels which are coming into the vitreous cavity which do respond to anti-VEGF very well.
When anti-VEGF induction of PVD becomes slightly easier because the fleshy vitreous is difficult to remove from the surface of the retina, but if the same vitreous becomes a little fibrous following the use of anti-VEGF, the cleavage planes become much easier to enter and remove in total.
I come across with one having edges, and it was a little flatter, and it was poking the lens also, and the patient was very young. There was no cataract, and I tried to remove through the corneal with the forceps, but it fell down inside. So
Which foreign body was this?
Metallic foreign.
Metallic.
So in young age, the cataract, the lens strength is not much. So I think it went inside. When I was trying to remove with the forceps, I find the case very simple, but it turned out to be very complicated later on.
Traumas
So
are
whether we
mistake.
should use magnet in such cases?
See, one is that what you're talking about, probably there could be a possibility that in these patients that yes, you can have this problem because the patient is young, the lens is soft, and while you're trying to manipulate the foreign body may go down. I did not understand whether you tried removing this foreign body through the wound, trauma wound, or you
I
tried
tried
separate.
first through the wound, later on I closed the wound, and then I tried from the limbus. But still it was not able to, I was not able to remove it.
I think you need to expect the unexpected. One of the useful tools in your hand would have been using a magnet. Using a magnet, exactly, because these metallic foreign bodies, if you try to hold it with a larger forceps or even with a tiny forceps, it doesn't help. I have seen the superior rectus forceps sometimes is very useful if you are externally trying to grip the foreign body and bring it out. Sometimes, if it's a really large one.
Yeah, it was large.
Yeah, so it will slash the retina and cause more damage, if I am not mistaken, and choroidal bleeding and all those things. Other thing is, if already there is a PC opening, you can probably go with the other sclerotomy, keep a forceps or something or light pipe behind it to just give it a little bit of support. Because whether cataract is there or not there, if it has slashed the PC anyway, the lens has to come out. You cannot save the lens.
But magnet was...
Magnet would have been extremely useful. You would have dislodged it before brought it safely into the iris above.
I was not knowing that
So if you bring it above the iris, then this kind of situation happening becomes very less because the iris diaphragm takes care of it. And then you, with the sturdy forceps, you need to hold it properly and then bring it up.
You would have even seen in the video, one of the videos where Dr. Pukhraj showed the glass foreign body. It's very difficult. Glass foreign bodies are very large, they are very slippery, and it's not easy to hold these foreign bodies with any kind of forceps, and that was the superior rectus forceps which was used to help that glass foreign body to remove.
So and it is in the AC, in the grade 2 or 3 lesion in the AC, and the mild vitritis in the vitreous. And there is a very normal, very little posterior capsular cataract. So I take a suture or anything like that, the things are going to change.
Where is the foreign body?
Foreign body is in the AC, antechamber.
You can think of the removal very well. Is it involving the lens?
It is not involving the lens. Whatever I was able to appreciate is that there is only PSCC.
So that can be a traumatic blunt trauma also which would have caused.
It is a penetrating trauma actually.
No. Even a rosette cataract can form with a blunt, with a trauma.
Okay.
It may not be the impact of the foreign body per se. So where exactly is it still? It may be still lying anteriorly and it has not breached the capsule. You can just use a good viscoelastic and try to still remove it, because still there is a possibility of infection in these patients.
IFP has to come out, even if vision is 6-6. Vision has nothing to do with intraocular body. I think that answers your question.
And if you are really small, you're in the AC